thank you so much for joining us. As usual, my name is Christine Kennedy, and on behalf of the Office of Alumni Engagement and McMaster Continuing Education, I'd like to thank you for joining us this evening for our first Caregivers Essential webinar of the 2024-25 series, Who Cares? Current and Future Challenges for an Aging Canada. Before I introduce our speakers for this evening, Donna Thomson and Dr. Samir Sinha, I'd like to begin by acknowledging the land on which this webinar is taking place. McMaster University recognizes and acknowledges that it is located on the traditional territories of the Haudenosaunee and Mississauga nations and within the lands protected by the Dish with One Spoon Wampum Agreement. So I'd like to introduce our moderator this evening, Donna Thomson. Donna is a caregiver, author, and educator. She is the author of 2 best-selling books on caregiving, including The Unexpected Journey of Caring. Donna also facilitates our free online course for caregivers, Caregiving Essentials. She is a co-designer of the Creating Caregiver-Friendly Workplaces, which is a new course that was launched just in April. And she is also the co-designer and co-instructor of the Family Engagement in Research course, all of which are at McMaster. And joining her this evening is Dr. Samir Sinha. He is a passionate and respected advocate for the needs of older adults. He is the Director of Geriatrics at Sinai Health System and the University Health Network, just over in Toronto, up the road from McMaster. And he is also Professor of Medicine at the University of Toronto and the Director of Health Policy Research at TMU University's National Institute on Aging. A Rhodes Scholar, Samir is a highly regarded clinician and international expert in the care of older adults. He was recently appointed to serve as a member of the Government of Canada's National Seniors Council and is also leading the development of a new national long-term care standards for Canada. Thank you, Dr. Sinha, for joining us this evening. Donna, I'll hand it over to you.
Oh, thank you so much, Christine. And I am absolutely thrilled to be here tonight with my friend and someone that I respect and just hold in such high esteem, Dr. Samir Sinha. And Samir, welcome to Caregiving Essentials. And we're really, beyond thrilled that you're here with us to kick off this year because the course runs continuously until next August. So, you and I were just chatting, I guess it was last week, about what we were going to talk about tonight. And we have so many questions that people have sent in, and we're not going to be able to get to all of them. But I guess the first thing that I wanted to ask you is, you are Canada's preeminent gerontologist, geriatric clinician. How did you get interested in this field? What was it that brought you to the study of geriatric medicine?
Thanks again, Donna, for the warm welcome and for inviting me to be part of this year's inaugural course, if you will. It's and we've known each other for almost a decade. I was just thinking about that when we started working on the Government of Ontario's home care strategy. I think that's when we first met, and we became thick as thieves. We were guided by our similar passions to make things so much better for caregivers and for older people alike. And we're still at it. So, but as you ask, so what got me passionate? I know what got you passionate about caregiving. You became a caregiver, and it was unexpected, and for me, my journey into geriatric medicine was a bit unexpected as well. I went to med school because I wanted to help people. I became really interested in wanting to support, vulnerable populations. And I started doing work as a medical student, focusing on Indigenous communities, especially in my home province of Manitoba. And I became very keen on saying, how do we actually better support populations who have been underrepresented, underserved? And that actually is some of the work that landed me in the UK and England. And it was actually my mentor there who said, we don't have Indigenous people in England, but you're clearly interested in working with vulnerable populations. And one that's a universal population in England and the world over, including in Indigenous communities, are older people. And he said, have you ever thought about maybe focusing your policy and your future studies around using older people and their issues and challenges as a case study, as the basis of your work? And that's actually how I ended up as a medical student, thinking about care of older adults, care of older people. And I became hooked from a policy standpoint. I became hooked from it was a fascinating area. It was a whole new area of care because, life expectancy in 1900 was 51 years of age. So this whole idea of aging is still a relatively young phenomenon, believe it or not. But when I returned to Toronto to do my internal medicine training, I decided to have a go and do geriatric medicine as one of my first rotations. And that's when the practice met the policy. That's where I really found my calling as a physician. And I said, this is a vulnerable population that needs more geriatricians because the New York Times calls us a rare and endangered species of physician. So I decided to, join the herd, if you will, if I can call myself that, and jump right in. And honestly, I couldn't think of why anybody would want to do anything else than geriatric medicine. It gives me permission to care for the whole patient, and often that's including caring for their caregiver as well.
It's so interesting. I remember hearing you speak in Ottawa, and it was at an event for the alumni of the University of Ottawa, and you were presenting that evening on geriatric medicine, on your career, and I remember you saying that night that you really put a call out to, the alumni, but also to medical education writ large in Canada and North America and the world for more medical education in the area of geriatrics. And I think I recall you calling for a mandatory rotation in geriatrics simply based on population health. Can you talk a little bit about that?
Yeah, well, when you think about what people actually learn in medical school or even schools of nursing or social work or therapy, some of these curriculums, for specialties and professions that have been around for generations, that curriculum almost kind of looks like it did 100 years ago, if you will. And you have to remember that geriatrics as a term was only coined, I think, in about 1916. The specialty itself only became recognized as one in Canada in 1982. I think England was the first country that really, declared it a specialty, and that was after the war. So this is a relatively young area of medicine, believe it or not. And of course, then when you're saying, wait a minute, our population's aging, they need a specialty of geriatric medicine. Well, we should make sure doctors have this knowledge. The challenge is then you have this curriculum that's already quite crowded. And then, people say, well, where are we going to fit that in? And do we need to fit it in? Is it really that important? I think partly, if you just look at the numbers, well, one in five Canadians today is an older Canadian. Soon it's going to be 1 in 4. And when you think about who are the greatest users of our healthcare services overall, it is older people. And so you have to naturally think that, well, this is a no-brainer. Unless you're a pediatrician, you are probably going to be caring for older adults. And just like in pediatrics, we recognize that children aren't just little people, but they're biologically different. They need different approaches to the way you treat illness and disease. And the same is true for older people. But for some reason, I don't know if it's ageism or just kind of this assumption that older people are just chronologically mature. They're just older adults, which they are older adults, but they actually have unique needs. And I think once you recognize that, you realize that, just like we focus on pediatrics in every medical school, we do need to be focusing on geriatrics. And so I have to say the majority of medical schools in Canada still do mandate geriatric training. After 14 years at the University of Toronto, this is going to be the very first year coming up where all medical students will have to have done a rotation in geriatric medicine. But that's after 14 years of me being persistent. And Donna, you know how
Yeah.
persistent I can be. But even I think McMaster still doesn't have a mandatory geriatrics program. So we need to get on this, because if we're graduating doctors who don't actually have a core level of expertise in this area, it's going to be hard for them to be great doctors. And that goes for all other sorts of health professionals out there. We need to make sure that they are well prepared for caring for the population in front of us.
Yeah. Oh gosh, absolutely. I mean, I'm next year I'm turning 70. So I have a lot of personal interest in making sure that my future includes good care.
So do
Um,
I, right? I mean, again,
yeah.
right? I think all of us should have a vested interest in making sure that whoever is caring for us is well trained to care for us. And I always joke that's why I got into this, because it's going to take a long time to change the system. So I might as well get started early, because hopefully it'll be figured out by the time I become lucky enough to be an older adult. But you're right, we all have a vested interest in getting this to where it needs to be.
Yeah. And ageism in medicine and in medical education and in society generally is a huge worry, a huge concern. Um, Ableism too, and often people age into disability. Once you retire, you're no longer, theoretically a, a producing unit of society, and your human worth kind of diminishes accordingly. And that is scary. And I'm very, very grateful that people like you are championing the human worth of people. It's worth um, having people trained in geriatrics and good care for older adults, because we will be, in the future, huge numbers in society, and we have families who love us and we love them. Sometimes I think that matters. Relationships matter, and they, by definition, give us worth and meaning too. So, but and I'm sure that we'll touch on the whole issue of ageism again in our conversation. But Samir, I want to ask you, what do you think is going well right now? And then in a minute, we'll get on to what are our biggest challenges moving into the future. But currently, what gives you hope? What's going well in Canada for older adults?
Well, I think we have many more older adults. I think that's a great sign of success, right? Because as I said, in 1900, our life expectancy as Canadians was 51 years of age. Now it's in our early 80s. And so when people say, what was the greatest accomplishment of the last century? Some people say we put a person on the moon. I'm like, we almost doubled our life expectancy. That's exciting, because now we have more people who can, live longer lives, and often healthier lives too. And one of the things I call that is our longevity dividend, right? I'm sure, Donna, you have been able to pursue all sorts of interesting things and new adventures, kind of. Nobody retires. I don't want to call it your retirement, because yeah, I've
No,
never known you to
no.
be retired, but it's more the idea that, and I'm sure, as you approach your 70th year, you're probably thinking about all the things you've got plans to do and see. And that's exciting that we have this longevity dividend that we've actually all earned. And, to your other point about, how we kind of look at older people as non-producers. In fact, there's a economic term called the dependency ratio, where we actually look and say, we look at all the older people in our society, and we against the people between 18 and 65 who are working, and we basically treat those people who are of working age as producers, and the people who are not of working age as basically takers, basically kind of almost useless eaters, if you will. And, and this is the challenge. I hate that term dependency ratio because it forgets that older people in our society who might have more free time on their hands actually can choose how they want to use it. And often they invest that time in our communities as volunteers, as caregivers. They're some of the biggest providers of unpaid childcare, elder care, all sorts of care. And so tell me how that's actually not a contribution. That's actually some of the glue that actually holds our healthcare system together, that actually holds our societies together. And then, as you said, right, there's that whole intergenerational wealth of knowledge. I mean, if, having an older person in your life who has wisdom and experience that can only come, with time, when you start actually reframing it, older people are assets, and we need to appreciate that. And the more we can actually allow people to live longer and healthier lives, that becomes, an asset that we can mine in so many different ways to make our society better. But again, we've just been living in a society that has tended to look negatively at older people and not really see them as assets, but more about liabilities. And I think when we reframe it properly, we realize how mistaken we've been.
Oh, absolutely. Absolutely. I couldn't agree more. Um, and, there are movements like the asset-based community development movement and looking at neighborhoods and looking at everyone who lives in the neighborhood, all ages are constitute assets. And yeah, it's funny, because being an older adult myself and my husband, we have this little neighbor who's, I'm going to say 4 years old, and he comes and rings our doorbell every day. And he shows us what he got for his birthday, or he just wants to visit. He pops in for maybe 5 minutes, and he is hilarious. And we hear from his parents how much he loves us, and we love him. And when I think about the things that make my life very rich, that's one of them. It's one of those informal relationships in a neighborhood, hyper local. This little guy checks in on us every day, and I think that we do have these informal, natural forms of natural care occurring throughout society that's intergenerational. And personally, I think we need to identify that, name it, value it, and support it, because it's what is making life safe and happy and joyful and good for many people. Um, Samir, I'm wondering, what do you think are our big challenges as we move forward with exploding, I guess maybe that's too strong a term, but exploding numbers of people in my demographic and older?
Yeah, I mean, when you start thinking about it, I mean, people sometimes say exploding, or, a term that I really hate is this idea of the silver tsunami, right?
Tsunami.
People talk about, kind of aging as this apocalyptic, kind of phenomenon that's just kind of happening without warning. But anybody who's listening and has heard of the baby boom, we've known what our demographics were going to be, decades ago. We actually know what Canada will look like, in 5 years, 10 years, even 50 years ahead. And pretty much everything that's charted out has been coming true. So we know exactly how things are going to play out. And soon 1 in 4 of us is going to be an older Canadian. We're going to have 30% fewer available family members to provide unpaid care, over the next 30 years. Why? Because, we are going to have we're having smaller families. We're less likely to have children, so that some of those natural caregivers that you might have as children and family members just won't be available, for example. So we know what our demographics are going to look like. And so I hate using the term exploding or tsunami or these things, because I feel like it really gets us all off the hook. I like to use the term aging glacier, because this is something that's been happening slowly but surely, as predicted. We know what's going on. And frankly, we're the ones to blame because our biggest challenge is we haven't really done much to prepare to meet the needs of an aging population. I mean, the good news is we actually know the things that work. We know the things that actually, the types of models of care that actually better support older people through their healthcare journeys. We know about things that actually can support caregivers to have less stress and feel better supported and engaged. We know the types of care that older people want, i.e., staying in their own homes and communities as long as possible. And we know it's actually cheaper to do that. So we actually know a lot of what we need to do. The biggest challenge is we're just not doing it. And I think that is the biggest problem, because the more we delay actually implementing the models of care that have been well proven, and the tactics that actually help us not only manage but actually thrive with an aging population, the more we're going to leave ourselves behind. So I think that's our challenge, but it's also our opportunity to actually right size the ship, if you will, or right the ship. That's the term we're using, and really make this not a tragedy, but a story of success and resilience as a society.
Hmm. Oh, it's so hard though, because I mean, as somebody who I cared for my mother who lived with dementia until she died at age 96. She died in 2018, thank goodness, before the pandemic. But also care for our son, whom, as you know, has cerebral palsy and is medically complex. Um, and aging in place, aging at home is a great idea. And, when we were on the same committee looking at home care restructuring, for example, it's very, very difficult to reimagine public funds being repurposed in a way that truly enables people to remain in their own homes safely, with care, and with dignity. That's what we all want, but um, it's really hard to find people to help, if especially if you don't have kids or adult sons and daughters or nieces and nephews or neighbors who step in to pitch in. So what do we do in a situation, for example, with someone who has limited funds for private care and wants to remain in their home and doesn't have children? We call a person like that an elder orphan. What is the response? Do you believe, what should the response be? And what should the social contract be for someone like that and their claim on public funds and mix of paid, unpaid care? How does somebody do it?
Yeah, it's tough because right now we have a system and we have a society, that's a bit muddled in its social contract, right? I think a lot of people are very proud, their chests puff up when we talk about Medicare and in Canada, and I think people often think that Medicare covers kind of all of our health and social care needs, but it
No,
doesn't.
it
It
doesn't.
really only covers physician services and hospital services. That's it. We never created a universal healthcare system like other countries that includes prescription and medication coverage, that includes the provision of long-term care services, whether it be care in a long-term care home or home and community care. So we have a lot of big gaps in our actual kind of healthcare system, our health and social care system. And I think so it's a rude awakening. So I think for a lot of people, they actually go through a lot of their lives just knowing that if they need help, it's often covered, it's free, because a lot of our healthcare system was designed and launched at a time in the 60s when the average Canadian was 27 years of age, and most of us didn't live beyond our 60s. So we have to understand the context of why we created the system we have. The challenge now is our current social contract doesn't guarantee anybody the supports they'll need to stay in their own homes and community unlike our social contract that guarantees that if you're sick and you go to a hospital, we'll do whatever you need and there's not a bill to see. So I think the reality is for a lot of my older patients, for example, who don't have family members or friends close at hand, who don't actually have much in the way of savings, options become quite limited because beyond what the government is willing to do, which might be a few hours of home care at most every day, you're otherwise on your own. And if you can't afford additional private supports or you can't make friends who might be able to pitch in your care, then your options become quite limited pretty quickly. And I'll be honest, in these cases, sometimes the right place ends up being a long-term care home, because that's ultimately, if you don't have people there to care for you and you can't pay for other people to provide you the care to stay in your own home, then we've created long-term care homes almost as a bit of a social safety net. But it's a very expensive net, to be casting, if you will, for people who might be limited in their resources and their supports. And that's why I look to other countries like Denmark, where they've kind of, they haven't figured it all out, for example, but they're really keen on making sure that older people can live with dignity and in a reasonable way. And so one thing that I think is very clever is they have a whole range of housing available for older adults, for example, that's very simple. It might be a very simple apartment, maybe 500, 600 square feet, or a house of that size, where there's only 4 rooms. There's a living room, there's a kitchen, there's a bedroom, there's a bathroom. That's it. Pretty basic, but it's yours, right? You can make it your home, for example, but it's designed to be fully accessible. And they're developed in neighborhoods or in a building. And the cool thing about it is that it's organized at a funding rate that most people can afford, for example. So it's some basic housing that can allow people to live in their own apartment or live in their own home and not necessarily live in a long-term care home. And then, they might be able to be supported by a bit of home care and other supports. So they don't actually end up having to go live in an institution just because they don't have family members or friends. That's a very expensive kind of solution. But in Denmark, they've actually created some of these really cool intermediary levels of support that really kind of use tax dollars effectively and give people more of the support that they want and need. So, to your point, there are people who don't have as many assets they can draw upon, but it also makes us it's helpful for us to understand what we can be doing as a society to support people so that we don't actually have to support them in more expensive ways that cost all of us unnecessary sums of money.
Mm-hmm. Yeah, and we learned so much about long-term care and what works and what doesn't work during the pandemic. Um, and I know that you speak a lot, Samir, about the idea of small long-term care homes that are in neighborhoods that are, uh, not more than, say, 12 beds or so like that. My mother lived in one of those at the end in assisted living after she kind of graduated from an apartment style autonomous seniors home. She moved into a small, um, a renovated Victorian house in a very pretty neighborhood in Montreal. And she was able in that home to dry the dishes if she felt like it. She folded laundry. She gave shoulder massage to her caregivers. It was very natural, I would say. It was not institutional. Is that what you think of? Is that sort of scenario what you think of, kind of the Eden model of care where the staff does everything? Everybody's not like chopped up into I do nursing, I do cleaning. What is it that you have in mind when you speak publicly about small homes? And I've heard you say, we know they work.
Yeah, and you described it really, really nicely because, when we were developing the new national long-term care standards, we actually engaged close to 20,000 Canadians and, long-term care residents, older people, caregivers, when we asked them like, what do you want, your long-term care experience to look like? People wanted their settings to be home-like. They didn't want it to be institutional. They wanted to have the dignity of their own room, not having to share with a roommate, not having to share with multiple roommates. Sometimes, people are okay with that, but in many cases, it's just this dignity, and we know that actually, and when you're in, kind of a big place where there's like 30 in a unit, for example, it can be big, it can be impersonal, it's a bit crowded, for example. And so being in a home-like environment, in your case, in your mom's case, a house, for example, where she had her own room, right? So she could have her own privacy when she wanted it, but she could also be able to interact with not 30 people, but maybe, 11 other people and some caregivers who were kind of like she was living in a house. She was living with family members who were helping to provide her care and support. And she was providing care and support in her own way too. I mean, that really, it sounds so basic in some ways, but it actually it makes sense. And the cool thing was that when you actually look at this as a model of long-term care, we know that it actually results in better health outcomes. Right. And so less overall downstream hospital or other healthcare costs. We know that the staff enjoy it because they're basically just being able to care for the whole person, and they're there and they're part of a small family. They get to know people really well. We know by having your own room, for example, it's really good from an infection prevention and control standpoint. So that's why we saw these homes do so much better than traditional nursing homes during the COVID-19 pandemic. And we know that even for like, here we're talking about caregivers as part of this webinar. We know that even families, feel more welcome in these environments because you're visiting your loved one in their home. It literally is their home. You're at a dining table where they and 11 other family members or roommates, if you will, live together, for example. And interestingly, I've heard, families end up becoming more engaged in these environments than in a big impersonal kind of care setting because you feel like you're part of the household. Because if you went, for example, to visit, you might have helped mom fold some of the laundry. You might have peeled some potatoes and stuff and or said, hey, maybe I can bake a cake because I know you and your colleagues like that, for example. And I think once you start thinking about how simple and basic, but how natural this sounds, it's incredible when you see that the data really stacks up and says this is actually what people want. And the cool thing about small household models is you can build these anywhere. You can build these in really rural and remote communities. They can fit nicely into neighborhoods. So you don't need to find a big piece of land to build a big institution. You just need to find a parcel of land where you can just build a house. You can stack these on top of each other in like a condo tower, which has households of 10 or 12 people. So it just, and the cool thing about it is, why is it that we're still okay in our society? Maybe it's just the ageism, warehousing older people in big institutional settings for their care. But when it comes to hospices, community living settings, in so many other examples of care, we have graduated or gravitated towards a household model. Yet somehow we've just been persistent in North America about building even bigger institutional places where we can efficiently and effectively care for a bunch of these people on an industrial scale.
Yeah, and it's still going on today. There are announcements all the time about new long-term care, 300 beds. Who's going to staff them? I have no idea. But one of the things that really interests me, coming back to caregiving and families, is, you know, I think as you said, in the context of aging and care, in a small family style home that's in a community, those residents can be a family
Mhm.
still. within the four walls of their room, their home. Um, because I always ask myself, how can we be a family when mom moves into long-term care, when our son moved into long-term care?
Mhm.
How how can we be a family when we're not together anymore? And there is this artificial barrier between us that is that need for care, that that is, I mean, it's just hard to kind of um, cry in a public space in long-term care with your mom if she's upset. Do you know what I mean? Like your
Yeah.
stuff you would do in your private family home, you can't do in an institutional setting. And then all of a sudden, oh, so my mom isn't really my mom anymore. It doesn't feel normal or natural. I don't know what it's going to take to get um, our governments, and maybe you know through the National Aging Strategy, Samir, through the Ontario strategy, through the National Institute on Aging, what can we do to get people to see the light of what people truly want and need? And I'm including family caregivers here too.
Yeah, no, I mean, I think the key is the good news is we're actually, we've got the answers. The answers are actually in front of us because people have been pioneering all sorts of different ideas and things. We're just naturally inclined to try out different things. And so I have fun through the National Institute on Aging, the NIA, in recording this and putting it together in more comprehensive reports that really kind of put it all together and make it easier for decision makers and policymakers and the media and older people themselves to understand. Like this is actually how this could work. This could make sense because you made a comment just a few minutes ago about like who's going to staff all these homes. Well, you're right. In these traditional long-term care settings, they can be incredibly demoralizing places to work as well. Staff don't really last that long in those settings. Maybe within a year, there's about 40% turnover. In some settings, I've heard turnovers of over 130%, for example. Like that's just kind of, what happens, and that doesn't lead to good care. Whereas when you actually look at these small care, household models where people are invited to just bring themselves to care in a natural way, all of a sudden you see that the retention rates in these settings are really high. The satisfaction rates amongst workers is high because they're not, you know, doing certain things and not others. They're just allowed to provide care in a natural way, and I think that's where you see what the solutions can be. So, how do we move the ball forward? I think it's about educating ourselves. It's about putting the evidence together and then making a clear business case, if you will, to government to say that we'd be silly not to do this. Because I know governments are really worried about escalating healthcare costs and how are we going to sustain our health and social care systems. Well, if you look at other countries that have really been much bolder in these spaces, in these areas, and actually done some of this good quality work, and are doing these sorts of models like Denmark, like the Netherlands, their systems are so much more sustainable than ours. They're not having the drama and the issues that we are having because it just makes sense and they've shown that it can work. So I really feel that by educating ourselves, educating each other, and just reinforcing these messages, eventually someone's got to listen. And I want to be ready to help, make sure that, when a decision needs to be made, we've got the answers, the best answers available.
Yeah. So people who are listening, Samir, who want to maybe get involved to advocate for these type of solutions, here in Ontario or across the country, what can individuals do to support this vision?
Well, I think part of it is just, kind of if people are interested in a topic or any sort of issue, it's make sure you learn, kind of, what are the issues, what are the solutions. And then the key thing is, I always remind people the number one goal of the Minister of Health of Ontario or the Minister of Health of Canada is to actually get reelected. That's their number one goal. I think when we realize that, it's like, oh, yeah, that makes sense. They are politicians first and foremost. That's kind of their job. And so they're going to do what voters want them to do. And if voters basically say loud and clear, we don't want to be building all these big box warehouses. We want to have care closer to home and in our homes whenever possible. We want to move towards small care home models. We want to make sure that our caregivers are supported. We want to do these things. It's not want, and cost. It's the idea that there's a lot of good evidence that when you do these things, you can actually save money for the overall system and actually provide more of the right kind of care that people want and need. And so I think when you tell your politicians this, then maybe they'll get less excited about pushing forward to build all these big buildings where people don't want to go and actually say, oh, so if you want more home care, maybe we should put more in home care. And then when you can back that up, not just saying what you want, but with good data and a real good case as to why it makes sense, that's actually how we start to get change in action as it needs to be. So, while we see all sorts of interesting kind of political machinations occurring, I know you and I, Donna, we keep, plodding away, making sure that we do the work that needs to be done. We write the papers that need to be the books that you've written, so that when people are ready to listen and ready to actually take the issue seriously, we can give them some really good, clear advice and guidance on how to get to where we need to be.
Yeah, absolutely. I have two quick more questions before we get to so many questions, great questions from the audience too. But you know, I'm just curious, Samir, you are in this field, you know so much about what works and what doesn't work. And I'm wondering how you are planning for your own aging. How are you doing that yourself?
Yeah, so I'm what you might call a bit of a solo ager, for example. So I do have a partner, but we don't have kids, for example. And so it's not that, and I know even people that have families, for example, they might say I'm going to have children because they're going to care for me. Well, that's not necessarily a guarantee. You can't be certain. So I've often thought about, okay, so what does, aging well look like for me? Well, I do want to stay in my own home and community, but if I needed to be in long-term care, probably would want to be in a small care home as well, because that kind of could be fun. I like to be in the company of others, but I want to have my own room in that way. But in the time being, I love my neighborhood. I love where I live. I love the restaurants around, and so my plan is I have a two-bedroom apartment in downtown Toronto. It's a single-story setup, so there's no stairs that I have to navigate. All the door widths are actually 36 inches wide, meaning I can push a wheelchair walker through any of them because the international width for wheelchairs and walkers is 32 inches. And, I'm saving my money. I'm not spending it on children, but what I am doing is I'm putting that money away so that, when I do need care, and I think I eventually will need care, I can hire a personal support worker. They'll have the second bedroom, which is quite lovely, nice view, their own ensuite, nice quality living space. And I'm going to pay them 25% above the market rate, because I want to make sure that they're well supported and they're happy because my happiness depends on their happiness. And we'll have fun, I don't think I'm going to love Meals on Wheels, but I know there are great restaurants all around and we can go and grab food there, or they can grab food for me and send it up. That's kind of how I plan. That's how I'm thinking about my future. But you can't be a geriatrician and not think about what the future will hold. But I'm kind of, I feel very
Okay.
comfortable with that, and I feel like that's my plan.
Yeah, that's cool. Well, it's very similar to my plan. I'm trying to convince my husband. He's less keen on having people live in, but that's okay. I'll bring him around. But Samir, I'm noticing boxes behind you, and I know that you are getting ready imminently to move. Can you tell us about that and what you're going to be working on?
Yeah, so I've just finished 14 years as the head of geriatrics for Sinai and the University Health Network in Toronto. And while I'm still always going to be a geriatrician, I'm now wanting to focus more of my time to do the research that I love to do. So I'm going to be transitioning into role as a clinician scientist. And when I started thinking about what new areas do I want to really focus on, I'm really fascinated about kind of, what are some of the practical and ethical implications of using digital technologies and AI to enable healthy aging and aging in the right place. That's a mouthful, but it's kind of the idea that right now, aging is a big challenge facing our society. There's all this stuff happening with digital technologies and AI. Everyone's talking about it, a buzz. And I think a lot of people have this idea of techno solutionism. Well, it's just going to solve all our problems. But already we're actually finding that, with new technologies and things come new problems and new opportunities. And so how do we actually make sure that this is going to really be set up for success to help us with issues of aging, support people living with dementia, adapt to changes that occur naturally with aging, and also how do we think about caregivers and care providers, and really navigating that. So this is a big topic, and I've been and some of the great work that's happening and thinking about this is at Oxford University, in the UK. And so I'm actually about to get on a plane and go over to Oxford, where I did my master's and PhD, to reunite with my mentors who are still there, who said, come home. And I'm going to be doing a visiting fellowship there to look at these topics, look at these issues, and have the time to think, so that I can come up and develop some guidance and thinking in the space that might help us navigate this future together. And so that's what I'm really excited about. But yeah, of course, in order to get there, you got to pack and you got to like get everything, all your ducks in a row, and so yeah, I'm in that, kind of, last little sprint. But oh my goodness, Donna, when I get on that plane, I'm going to sit back and and sleep
Glass of
and
champagne.
champagne and watch a movie or something. I don't know, but I'm so excited about landing there next Monday morning and just getting right at it. So it's going to be fun and it's going to be a great year. And I'm looking forward to sharing with everyone kind of what I learn, after this year away on a sabbatical, for when I return back to Canada.
Yeah. Oh, it's going to be fabulous. I know. And they're lucky to have you too. Um, you and I were chatting, and I just want to make sure that people understand some of the real world implications of this work in AI that we were talking about. For example, with people with dementia, their family caregiver might give them a watch which has a GPS tracker in it, or there are even insoles that you can use in people's shoes that have GPS in them. And you were saying to me, Samir, that, did anyone ask their permission that these devices are being used? And that question to me was such a, well, I never even thought of the ethical concern of asking someone with dementia their permission. But I think what you're doing is just thinking more deeply and more into the future about the kind of advanced directives, for example, that people might want to be using, uh, safety. And this comes back to one of the questions that we had from the audience multiple times, is this balancing of people, individual, the patient, the older adult, maybe with health and safety concerns, but also a deep desire for independence. How do you balance risk and safety mitigation, with autonomy and the desire on the person's own behalf for independence? And sometimes maybe the individual also doesn't have insight into the risks that they are actually experiencing. So what are your thoughts about that? For example, that whole risk management thing that families are always doing, put the GPS on, never mind asking, this is about life and death of my mother or my father. What 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 do you think is the future, or do you have an idea of the direction of your research in this area? Because it's confounding, really.
Yeah, so let's use the example that you just raised, the GPS tracking, right? I see
Yeah.
that in practice all the time. And there's a broader principle that we can think about this, and it's this idea of living with risk, right? The idea that, okay, children under 18, under the age of majority, ultimately it's the parents who make decisions. That's how we've kind of structured in our society. That's kind of just how it is, right? Whereas after the age of 18, you can pretty much do whatever you want, for example. And of course, you think about our 20s, our 30s, whatever. We made lots of terrible decisions and lots of things that people would have said, wow, if they were me, they would not have done that. But anyways, I was allowed to do that. I was allowed to make bad decisions. But somehow when you become older and more vulnerable and frail, sometimes, we now start saying, well, I don't think that's a good decision, Mom, and I don't think that's that. But if that person's capable and competent, like nobody questioned them in their 20s and 30s, so why are we questioning them now, for example, if they're competent and capable? Now, sometimes, if I'm really worried about, a direction someone's going in, like a concerned friend, I might want to make sure, have you thought about all these issues? I just want to make sure that might put you in a bit of a risky state. What do you think about that? And they might say, oh, I've never thought about that, but they're like, oh yeah, no, I know, then that's fine. So think about this GPS tracking. The idea that if someone is, there are people who don't want to have people know where they are. They don't like the idea of being tracked. They just really don't want that. That's stalking in that way, and they might have really really deep concerns about that. And so they just don't want to be tracked. They don't want to be found. And you might say, "But Dad, you've got dementia, and I'm worried that you're going to wander off, and then something bad might happen." And they're like, "Yeah, I know I have dementia. I know that something bad can happen, but I really, really, really don't want to be tracked. I just don't like it." And if that's the case, we have to respect that, for example. Because again, if they're capable and they're competent, they're allowed to live with risk, and we have to respect that. But this is how I balance it now, because I often find, the people who are being tracked and nobody ever asks them. So now I've changed my practice by pausing and saying, Donna, Jim, your partner is really worried about you with your dementia, and the fact that, your risk of wandering. And in fact, that after you had that wandering episode a while back, that what they've done is they put a little air tag, they put it in your purse. And that way, and I appreciate that they've done that just in case if you ever get lost again, they can locate you. Is that okay with you? Right? And 9 times out of 10, people are like, absolutely. That's so nice. That's so great that they care about me. Sure. But then I've gotten your consent. I've explained to you what's going on, and then you've consented in that. And I had one couple I asked, and the husband's like, I've been tagged. And I'm like, oh. And he was sitting there with his wife, and I'm like, okay, well, clearly you're not. He said, I don't like this at all. I do not like this. Very fierce, independent guy. And I'm like, okay, well, let's talk about it, right? Because you appreciate why your wife is doing this for you. And they said, no, I understand why. I just don't like it. And I'm like, right. So do you not want to do this then? And he said, you know what? I don't like it, but I'm willing to do it because it gives her peace of mind. And so if it gives her peace of mind, I'm willing to do it. And so we got consent, but at least he was able to express it. And frankly, at least I think he felt he was heard, and that we heard his voice as well. And so I think it's a small thing, But I think again, it's bringing back the humanity in terms of what we care about. It's also making sure that we are respecting that person's right to refuse or that right to accept,
Mhm.
care and support. We're double checking in that way. And I think that's kind of an example of something that I will kind of help to write out a little bit more of a framework. Or there's some other interesting examples we're kind of cooking up about how do you negotiate those situations so you can take less. And so you can do things properly and respectfully, and you can balance that idea of living with risk as well. So these are whole new areas that we never really thought about. I mean, air tags are less than 5 years old, but all these new issues are popping up with that alone. And there's all these other things that when you start thinking about technology, we have to think about bias. We have to about digital divides. We have to think about digital discrimination. There's all these things that I'm like, wow, these are just fun things to think about. And how do we make things better for older people and caregivers? And one of the ways we do it, frankly, is by involving older people and caregivers in the design of these technologies, because they will actually say what works, what doesn't. And frankly, a business that wants to create something that'll be used by these individuals will be more successful if they actually took their thoughts into account right from the get-go.
Oh, yeah. I'm a huge fan, as you know, about patient and family engagement in research, right from the identification of the research question right through dissemination back to the community. We know that engaged research with the people who are most personally impacted by the research is going to be, the way of the future, I think. Samir, I'm just looking at the time and I'm sighing because we have so many questions that we would love to be able to get to that we've just running out of time. But I guess I do want to ask you um, something about, you were talking about Denmark and uh, the Scandinavian countries as being great examples of how to do aging well and to have public funds supporting that, and families, of course. I wondered what you thought about dementia villages. I know they exist. We're talking about risk, we're talking about AI, and I'm interested in what your thoughts are about putting people in situations where you're basically managing the risk to such an extent and making everything safe because it is effectively sort of a Potemkin village, an artificial environment. Lots of people love these. What do you think?
Well, again, as you said, right? Some people say, are these somewhat deceitful? For example, when you're going to the grocery store, but it's not a real grocery store, or you're sitting at a bus stop where a bus will never come there and stuff. And so, are we deceiving people with dementia and that? Two minds, right? I mean, again, this offers a lifestyle choice or a lifestyle opportunity that might be right for some, and for other people, they don't like the concept of that as well. So again, for some people, but I think a lot of these villages. They really are focused on living, and I think this is the key thing. They want people not to come and basically just kind of sit in a corridor with a whole bunch of other people and watch TV all day. They want people to be able to be in an environment where they can get out of the front door. They can go and wander around their community. They can be active members of their community, but do it in a safe way. And so I often think about dementia villages as being places for people to live and to experience things and to do things. And, and I always say, in some cases, for example, people say, if they, they sometimes, you're like, it's not a real grocery store and the person isn't really shopping, but so should we tell them that and that? And I'm like, you know what? If they're having fun and they're enjoying themselves, and then, let it be, for example, let them experience whatever they're experiencing on that. And I think I'm not opposed to these things at all. I just think, again, we have to figure out, who's right for them, and who are they, who are they ideally designed for. But I think certainly they can give another option, on a continuum of care that might work well for some people.
Yeah. Yeah, I actually agree with that. There are so many implications though, and many people are using chat to talk about um, you know, some of those implications and what they might be. Cameras, for example, and we could spend another couple of hours here and not even touch the iceberg of people's concerns and questions. Samir, I want to thank you so much for joining us tonight. It is such a pleasure to hear your thoughts and ideas, hopes, and intentions about how to shape the future of Canada and a healthy future for older adults in Canada too. So that includes me, and I am thrilled to be here and learn from you as always. And maybe I'll be able to come and visit you in Oxford too.
I would love that, Donna. And always, it's an absolute pleasure, as always, chatting away. And you said it doesn't just include you, it includes me as well. We're all in this
Yeah.
together, we're all
Yeah.
aging. And so we have an opportunity to learn from each other and really kind of help collaborate to figure out what are the solutions that are going to help us all age well as a society.
Yeah, absolutely. Thank you so much.